Hey guys, I am Michael Elskamp from Ontario, California. I am Group 2, and this is the Capstone Respiratory Care 480 video progress update. Our group scenario and goal. The group scenario: our facility has decided to pilot a post discharge wellness check program for high risk readmissions based on the CMS Hospital Readmissions Reduction Program. This group has been established as subject matter experts to develop a proposal and recommendations on this matter. The goal is to optimize our facility's post discharge practices for the CMS Hospital Readmissions Reduction Program. This proposal should provide any additional recommendations this group has for project success. So, our roles and responsibilities broken down. The registered nurse is responsible for communicating doctor's orders, explanation of treatments, identifying warning signs, along with patient education, importance of follow up appointments and treatment adherence, and assessing the patient's overall understanding. The pharmacist would be responsible for making sure the correct medication is being taken, communicating with the interdisciplinary team on medication dosing and frequency, providing patient education on prescribed medications, and reviewing possible discrepancies and contraindications to medications. The respiratory therapist would be responsible for education on respiratory related diseases, review of diagnosis and prognosis, explanation of treatment options and care plans, planning for home therapy options and equipment if necessary. The paramedic would be responsible for the review of medication and possible side effects. They could conduct home visits and health evaluations. They can reinforce and review patient education and treatment adherence. And lastly, they could ask the patient if they have any questions. Thank you.
Hi, my name is Lindsay Ford. I am from Charlotte, North Carolina, and I have been assigned the role as the pharmacist in our group scenario. So, our strategy. So, our initial plan was to address the clinical issue. And to do this, we broke it down to 4 questions. What are the contributing factors that are leading to these readmissions? How would their discharge plan look while still in house, or still in the hospital, and this involves assessment and planning? What is the discharge plan once they get home? And what does our discharge plan look like in the future? So our strategy was to break down the wellness plan into 3 categories. And these 3 categories consisted of in-house discharge planning, post-discharge, and then a long-term plan. So in our in-house discharge planning, this meant that we had to look at the initial assessment of the patient while they're still in the hospital. What resources and education must be given to the patient upon leaving the hospital. And during this step, each role, if applicable, would provide their assessment of the patient and meet as a multidisciplinary team to confirm education, resources, orders, and that the patient is competent and understands not only their diagnosis, but what the discharge plan encompasses. So, post discharge. So, the patient has left the hospital and now they're home. So, what follow up steps need to take place for the patient's discharge to be successful? And this involves scheduling follow up phone calls, home visits, reviewing and adjusting medications and therapies as needed. So, our long term plan. So, this plan would kind of involve the patient status, say in 6 months, a year, 3 years, etc. So now that the plan is in place and is up and running, we're looking kind of down the road and being proactive about potential needs down the line. So this may include constant adjustments of therapies and medications, maybe increasing routine home visits, or adjusting our follow-up visits with the patient. So now that the plan is in place and our strategy and everything is kind of up and running, we need to look at what our services would look like. So we would operate in a office space that's dedicated to this multidisciplinary team working together. Our personnel would consist of a supervising physician, a registered nurse, a respiratory therapist, a pharmacist, a paramedic, as well as case managers and social workers. We would operate Monday through Friday, 9 to 5, with on-call staff available for nights, weekends, and holiday coverage for emergencies and urgent follow-ups. Monday through Thursday would be dedicated to planning and educating and getting the patient ready for discharge, and then Fridays would be our discharging day. Having telemedicine capabilities, so having that technology for potential virtual follow-ups. And then our documentation would consist of using electronic health records such as Cerner or Epic.
Hello, I'm Shavakia. Um, I will be I'm going to discuss the quality and applicable support evidence and the success and the obstacles that we have associated with our supportive evidence. Um, First one we're going to discuss is the nursing person. For the application we use included the study we used included our nurse liaison for patient discharge and post-discharge was highly beneficial to our project. It requires a multidisciplinary healthcare team and a liaison for oversee the process of the essential and create a post discharge for the patient. The obstacles with this was the hospital that wanted to utilize the concept of liaison nursing position needed to adopt a certain practice according to each location, culture, personal beliefs, and not limited to include in the study. Concepts of this study help to minimize the discontinuity of care during the patient's discharge process from the nursing professional. The next area we will talk about is the clinical pharmacist, who have been known to identify and resolve medical errors during the discharge planning. The study showed that it impacted post-discharge home visits and the reduction for 30-day readmission in the chronically ill patients. Um, the success with this was an example of success was in the review of other studies where pharmacists intervene in correcting medical errors. The obstacle in this included studies that provided a home assessment of which can be essential to the patient's success and discharge. The respiratory therapist and the paramedic, the study we chose was used for interventions. It helped to reduce readmissions. Going over the interventions that we already had chose and making them redesigned to improve the outcomes of the patient. This article focused most on the interventions only. Um, the success was it showed an increase of the credibility of the findings because it used two independent researchers for the screening process. The study was weakness because the weakness or the obstacle that we had. The study was designed for qualitative analysis of the qualitative data. It varied greatly in the study, so it was no clear data on it. It was lack of quality data and insufficient reports. For the paramedic part, the article we used, it demonstrated post-discharge home visits and the reduction of 30-day readmission in chronically ill patients. The information acts as a guideline to optimize in newly established discharge programs with paramedics included. The success we got during this study was it was for large, diverse transitional care population and comprehensive claim, a detailed analysis of future admissions and total care costs across various clinical levels. The study's obstacle was that it was limited to medical population. It was limited to only the medical population in North Carolina and people on Medicaid. It didn't have a vast population. And
Hi, my name is Jovi Valarao, and my role in our group is one of a paramedic. Most of my responsibilities of our group scenario involve the detailed assessment of patients during their home visits. We'll be discussing evaluation metrics, current status of the project, and expected shortcomings. Starting with our metrics, we have selected four. First, our nurse is to conduct a thorough interview and questionnaire about the patient's post-discharge experience. Our pharmacist will conduct a medication competency, focusing on the patient's understanding of medications involving signs and symptoms and a teach-back method. Our respiratory therapist will conduct the patient skill and self-management competency, evaluating the patient's ability to administer their medications, closely monitoring their technique, while I, the paramedic, will do a quality of life survey to evaluate the patient's perceived health, assessing closely for any type of distress or problems with daily activities. Completed items in our group include the following, while our yet to be done items involve a group discussion about our strengths and weaknesses. Some examples of our expected shortcomings include low patient participation, survey fatigue, and any hurdles that involve cultural and socioeconomic barriers, items that we can anticipate but cannot correct until the project has been rolled out and we have gathered enough information to adjust. On behalf of the entire group, we would like to thank you for listening and following our progress very closely.